right. Good morning. Good morning. First of all, thank you all for joining. And what we will do is today, this is session number 26. I can't even believe that we made when I look back, I said to myself on a Wednesday, one Wednesday we decided, Selvi and myself, okay, this Sunday we're going to start the Zoom class. And we started and we futzed around, but I think we came along pretty good. And I really appreciate you all joining us. And today what we're going to do is Selvi is going to present a case, and it's an interesting case that she saw as part of, I believe, a screening colonoscopy. And in the midst, she found this large lesion and decided to take care of it. And Selvi, it's all yours.
Okay, thank you, Raju, so much. And I think if this endoscopy refresher, weekly Zoom sessions are a success, I think it's Raju and I can only take part of the credit. I think most of the credit belongs to all of the people who participate week in and week out, giving up your time on Sunday morning, Sunday afternoon, Sunday evening, depending on where you are in the world. And for your dedication and your interest and your feedback. And so thank you very much. I think the credit really goes to all of our participants who join us. So I'm Selvi Thirumurthi. We're doing endoscopy refresher session 26 today. I called this real world EMR. And I'd like to acknowledge Raju, my friend and colleague who put this session together. Angela Deal, I'm using one of her illustrations. She is fantastic. I especially want to thank the patients in the GI endoscopy lab staff, administration, and the physicians. Because when we saw this lesion and we were able to take care of it, everybody pitched in and helped out. One of the physicians helped with my schedule with a patient, and in the room I had Luis, who is one of the senior endoscopy technicians and fantastic, and Hazel, who is my endoscopy nurse. And with the two of them, I felt like I could do anything, and I did. You're going to see that today. I want to thank my institution, MD Anderson Cancer Center, for allowing us to use this platform. I did want to put a disclaimer in here that this video is being shown for educational purposes, specifically that I am not an expert in EMR. That's why this is called Real World EMR. And I'm also not an expert in video editing. So you will see that, but I wanted to share this video so that we would have some topics for discussion. So this is our patient. He's a 60-year-old man. He was recently diagnosed with prostate cancer. He was referred for a pre-radiation brachytherapy colonoscopy. His only past medical history is generalized idiopathic neuropathy. His wife was actually with him. They made an exception to allow the patient's wife to come into the hospital with him that day because he has trouble getting around because of this neuropathy. He's on gabapentin for this. He has no family history of colon cancer or other GI cancers. His last colonoscopy, when I asked them, was 6 years ago, done at an outside facility. And his wife reported that there were no polyps removed at that time. And on the screen on the right, you can see the lesion that we encountered. So the first step with any procedure is to examine the lesion. So this is a lesion that was located in the ascending colon. So the colon was pretty clean, given the fact that he had these limitations with neuropathy. He was able to do a pretty good bowel prep. He had some sigmoid diverticulosis. I got to the ascending colon and I saw this lesion probably 2-3 folds distal to the ileocecal valve and the cecum. So next we'll look at, so when I saw that lesion, I thought of this toy, and to me it looked like it was a dog bone. It looked like it was a big bone. And there's my dog with his toy there. Okay, so we will play the videos. So these videos are not as short as I could have made them, because as I said, I'm not an expert in video editing, but I did try to, the whole thing took more than an hour, and I knew I couldn't play the whole thing for everyone here start to finish. We would be here until Thanksgiving. So I I tried to clip it as best as I could. Raju, I don't know if you want people to discuss this part as the video's playing or not, but anyway.
As the video is going, maybe, you know, Sylvia saw this, the initial lesion, and Sriram, and how about Sylvia and Sriram take a shot at it and share what your thoughts on about the lesion, and what is the cancer risk, and how are you going to manage this?
I
And
think
Roy is also here, so Roy can also take a shot at it. So I'm putting Roy as a co-host.
okay.
Good morning, Roy.
In my opinion, this is a sessile lesion. So it is about 2.5 centimeter in the 2.5, let's say, per 1.5 centimeter. And at the first sight, I don't see any signs of deep submucosal invasion. I don't see converged folds. I don't see the epithelial surface looks normal. Though I don't see the proximal side very well. I will wait a bit. So it looks like an adenomatous polyp. And I think that endoscopic mucosal resection is the most suitable technique in this case, resection technique.
Selvi, can you go back to your previous slide where we can see the image? No, previous one. Yeah, okay, that's because then we have that. All right. I think that's what I would be thinking. And let me hear what Roy thinks and Sriram thinks. It's good to see what people think when they see a lesion and how do they manage. How about Sriram?
I agree with the previous comments about the suitability for EMR and it being sessile. Only thing I'm waiting for is a NBI image. There are two areas, I think about a centimeter from the left margin and a centimeter from the right margin, where there is a little vertical fold. Probably either it is a fold or there is some depression there that I want to clarify with the NBI. Otherwise, most of the surface looks smooth. So yeah, I think it is suitable for endoscopic resection. And it should be, it is parallel, it is somewhat linear, so a little bit of with a little orientation of the scope after injection, it should be able to come out in one piece.
Okay, Roy, what do you think?
I think if you look at the growth pattern of this lesion, it grows more to the side than going upward vertically. So this is whereby we have classified it as the LST non-granular. There isn't really any dome that I can appreciate, like the center of this lesion is not higher than the periphery of the lesion. Using the pragmatic classification, then I say this is an LST non-granular homogeneous, LST non-granular. LST non-granular elevated lesion. This based on the work by Sofia and others, I would say, then we can estimate the likelihood of this lesion to contain high-grade dysplasia submucosal invasion. Based on that, what I mean is that if there are points of high-grade dysplasia or submucosal invasion, it would be multi-foci and perhaps the risk is somewhere about maybe 2-3%. So that helps me to strategize on how to cut it. I would not want to be cutting this in multiple pieces. The most ideal is certainly to cut it in one piece. But then at that time, you need to gauge the risk of causing perforation. So maybe you say, well, maybe I can cut this in 2 pieces or 3 pieces, and then I will burn the edges using APC. I will also coagulate the base. Then I would be done with it. The next step I would be thinking about is that, okay, I have made that decision. I need to inject submucosally well, and I will then use a dynamic injection so that I have a good margin vertically.
Okay. I think that's a good point to think through. One of the things that you would see this thing is when we go to the next slide, right, let it play. Actually, one thing I would like to comment is this. I'm glad that Selvi actually did not edit this video too much. She got large clips of video. And as you can see, it was not easy to keep the position of the scope nice and stable, right? It is, my suspicion is that when we do see large lesions like this, and the patient is deeply sedated with propofol without intubation, then the respiratory movements can make a resection technically difficult because the right colon tends to move with diaphragmatic breathing. And if somebody is a little bit obese and somebody has a little bit of a short, thick neck, they can have airway obstruction. And when they have that, they breathe a lot with their tummy, and that makes it very hard to resect. So something to keep in mind when we are resecting a lesion and that we find during the screening procedure. We should be mentally prepared that it will be a little bit of a struggle as we cut it, because we will not have a stable operating field. Let me ask Selvi. I'm trying to think, am I going to ask Sylvia or Selvi? So I have to think, I'm a little bit slow.
Always think Sylvia, always Sylvia first.
So let me ask Selvi, you may want to comment on the patient, whether he was a little bit obese or whether he was having a little bit of abdominal breathing, because you see quite a bit of movement here.
Right, yes, definitely. Thank you for pointing that out. He did, I mean, he was not terribly obese, but he did have a lot of central obesity. And because we kept failing during the process, kept filling his abdomen to make sure at different points in the EMR process to make sure that it was still soft. And he, it's very deceptive when the patient's lying, like in Angela's picture, on the stretcher on their back. I don't at least have a good appreciation for how big they are, even though I, examine them, I pull the sheet down and I palpate their abdomen before the procedure to get a baseline evaluation. Once they're on their side and they're relaxed and their abdominal muscles are relaxed and all of that fat kind of just goes forward on the stretcher in the left lateral position, I'm always surprised by how much bigger patients are when they're asleep and when they're on their side. So he did have a lot of central obesity. This lesion was not a terribly stable position. So throughout the procedure, I did have to have Luis, my tech, hold the scope, as well as while I was kind of using both hands to do what I was, the task that I was doing at the time. It is on a little bit of a turn, and there was a lot of back and forth. I mean, as I said, I'm not an EMR expert, so I welcome any comments, and I don't know if I did this right or wrong, but I just, as I said, this is for educational purposes, and I'm not an expert in video editing. So I did larger clips, and so I appreciate everybody's patience as we kind of work through this.
Right.
But there was a lot of back and forth. This is all real. This is, you know, real world EMR.
No, the reason I wanted to make those points are people will tend to underestimate the morphological patients of a patient, features of a patient. You know, if somebody is obese, somebody has a short neck, you need to keep all those things in mind when you're operating. And especially when you are doing a screening exam, you didn't expect that you will find this large lesion.
Yeah.
You did the right thing in resecting that lesion at the time without bringing them again. But when you do that, what will happen is you have to be mentally prepared, a little bit calm to tackle these, the operating field that's not going to be stable. It's going to keep on moving up and down, up and down. And one of the things that one could ask the anesthetist or a nurse anesthetist to do is to put a trumpet, a nasal trumpet, to open up the airway so that it does actually make some difference to your resection. So another point is if you don't have anesthesia, anesthetist to do general anesthesia, one point to keep in mind is when you talk to your patient, you may tell the patient, hey, I want to make sure that you're comfortable. I'll make sure that you don't have pain, but I don't want to put you to deep sleep because I want you to help me by holding your breath at different points in my operation so that my operating field is stable. So that's what I've done for almost 4 or 5 years during my initial tenure at Anderson before we had anesthesia to help us with general anesthesia for all the EMRs. So, you know, I'm glad that you did it, although I can see it's a lot of struggle to do this.
So thanks, Raju. So this was of course, this was the first patient of the day for a full endoscopy schedule that I had. And I always ask when their last procedure was, if I don't find any records at MD Anderson in their chart. And so and this is just false sense of security, but when they said, oh, it was 6 years ago, I thought, well, this should be quick. we're not going to find, I mean, at the most, maybe some diminutive polyps or maybe a cell-ulcerated adenoma, but we're not, I mean, you know, this should be fine. But of course, this took time and this threw the whole schedule off. But when I saw the lesion and I knew that he had neuropathy and difficulty getting around and the prep I thought was good, I felt like I couldn't really bring him back for, you know, another COVID test, another prep, another procedure with somebody else. I felt, you know, the right thing to do was to try to tackle this lesion. So for better or for worse, that's what I did. And he got me. So that's what happened.
May I ask a question?
Yes, of course.
Because you had the chance to see the lesion, to have a close-up of this lesion and to dynamically inspect it. Did you have had the chance to insufflate some air and to assess whether it flattens by air insufflation? I'm not sure that I would classify this lesion as a laterally spreading tumor. It's a complex lesion. In my opinion, it's the height is still quite much compared with a width. So I'm not sure that I would classify it as a laterally spreading tumor, flat, non-granular, flat elevated type. What was your impression during the endoscopy?
So I did think that it was wider than it was tall.
Mm-hmm.
I did think that it was, you know, it spread more laterally than it was, you know, protuberant into the lumen. So, I mean, you guys are the experts with classification. I can just show you the lesion, but I did think that it was, you know, wider than tall.
Flat elevated, the risk of submucosal invasion would be about, let's say, 5%. And in a sessile lesion of similar size, the risk will be up to 30%. But again, it's a macroscopic estimation, and sometimes it's difficult to differentiate exactly between these subtypes.
Okay, well, I'm glad I didn't hear those numbers before I did this procedure then.
I think, hold on, what Sylvia is saying is that, okay, we all have an estimation that there is not a very small risk of submucosal invasion. It's certainly not less than 1, it's more than 3% probably. So then what we really need to do is that we need to confirm our impressions, and we need to get a good optical imaging diagnosis. Is there any areas that are consistent to have a nice type 3 or not? And then after that, then we can decide.
And maybe just a short, one more thought. When I can't differentiate between a sessile and a laterally spreading tumor, submucosal injection and lifting of the lesion will help me to make this differentiation. Probably we will see in a couple of minutes the submucosal injection, because flattening of the lesion will give us a better idea whether it's sessile or flat. Does it make sense?
Mm-hmm.
It's like an umbrella which you open and you better see the morphology.
Okay. Raju, shall we move on to the injection?
Yeah, please.
Okay. Okay, so this is some still images that I included from my procedure report, so that people can see it maybe a little bit more clearly, since I had to clip the video. But we can.
So let's go back to that image. I want
to
comment. Let's go back to the previous image. So one of the things that people need to keep in mind is whenever you have a lesion that is in the right half of the field and going into the right upper quadrant, that lesion is going to be hard to, you'll have difficulties in completing the resection. You will struggle because all your devices are going to come parallel to that field. They're not going to come at an angle. On the other hand, if that lesion is towards the left side, then you could, even if it's bigger than that, you will be able to complete the resection much faster because you're going to approach that in the right angle. So something to keep in mind, when you see a lesion that is predominantly on the right side of your field and your biopsy port, depending upon what scope you're using, is also in the right side down, then your instruments are going to come parallel to the lesion, and approach to that will be a little bit hard. So clipping will be hard. Injection probably not that hard. Snare resection is going to be hard. So something to keep in mind. And sometimes you may want to come out and reintroduce your scope to bring the lesion to the left side. But if the colon and the sigmoid area is fixed because of adhesions or whatever, you can do whatever, but you are stuck. And you still are stuck with a lesion like what Selvi is facing here. And you have to do whatever best you can do to take care of it in that particular area. But that will be a much longer procedure. I just wanted to make a comment about where the lesion is when you see the lesion, in terms of whether it's going to be easy to resect or difficult to resect. Just a thought to keep in mind.
Okay. So for this procedure, I use the pediatric colonoscope. That's what I use for colonoscopy, and I have the distal cap attachment. I've used all different types of injectates. This time I used Eleview, and I just clipped together some of the injection sites. I did multiple injection sites. Looking at the video, I think probably at least a half a dozen, kind of peripherally around the lesion, into the center of the lesion, and I just included some of those, including photo documentation around the edges, to show that we had a good lift. So I think it was 18 cc's of Eleview. that I used, and then to answer the question about what happened with injection. You guys can see, but it seemed to me like it was getting bigger and bigger with every injection. So that was something interesting.
Mhm.
I think you got a good lift.
Yeah, no, I did. It would have been a lot shorter procedure if I, didn't get the lift, but every time I injected it came up nicely. I had a really, as I said, a great expert endoscopy technician. He knew exactly how to do a good submucosal injection. You'll see that we didn't get any hematomas or submucosal blebs. It was just really nice submucosal injections that he did, I was very lucky there. So I'm examining around the perimeter of the lesion. Anything that doesn't look blue, I'm injecting more so that there's a good lift around the circumference. See, it just like doubled in size. The whole thing just doubled in size. I should have probably tried, Raju, to try to rotate the scope to get it on the left side. That I probably should have at least tried to do. But here we are.
Yeah, that's good. That's good injection. It makes a big difference to have an experienced technician
Yeah.
to help with the EMRs.
Yeah.
And
I think that was part of my decision-making process, honestly, because I saw the lesion and then I, looked at my schedule and I was like, this is the first case. And then just to go through my thought process. And then I looked at my team and I had, a fantastic team. And then I thought, well, you know what, I'm gonna do it. And the only reason that this was, at all minimally successful is because of, the great team that I had in the room. I can play this again, Raju. It's the end, so I'll just play it again. And if you want to make comments at whatever point you want me to advance to the next step.
I think one of the comments that I want to make for colleagues of mine from around the world, if they're interested in setting up an EMR practice, it is, I think, having an assistant who can help you and read your mind is the most important thing. And the way to do it is, I'll explain what we did. We started EMR practice at Anderson about maybe 10 years ago, 11 years ago. And at that time, we had one technician assigned to a particular room, and that assistant had that room assigned for the whole week or even months at a time. And so we trained one assistant to become proficient. And then once they became proficient, then take another assistant and then train. That's how we train all our assistants in the art of injection technique. Because if somebody can help you inject right, you can do EMR very easily. So I encourage you to consider that idea. If you're just starting and you have a bunch of technicians, most of them probably, if they don't know how to do, just get to one technician, get them up to speed first. It will take about 6 to 8 weeks for them to be comfortable doing a lot of EMRs, and also get into the habit of lifting and cutting polyps that are 5 millimeters or above, instead of doing a cold snare. That will help you learn and perfect the technique of resection using EMR technique for larger lesions. So something to keep in mind. And if you don't inject often, you will not, you and your team may not get into that habit. Just want to make that comment. We were discussing this yesterday I was discussing this, Roy and myself were discussing this point. All right, let's go to the next one. I think it's beautifully done. It's a good lift. At least we can say from this lift, we can say that there is no deep submucosal invasion. And sometimes you may see a little bit of submucosal invasion, but that doesn't really bother, especially in terms of the outcome.
May I make a short comment?
Please.
Now that the lesion is nicely injected and lifted, we can see indeed that originally it was a laterally spreading tumor of non-granular type, as Roy said, it's a progressed lesion. The central part still looks a little bit nodular to me, but I think that it was originally a laterally spreading tumor, non-granular type.
Okay. All right.
Okay, so the next thing that we did was resection. And I started with the 25mm snare to see how, both to size the lesion and to be able to see if I could get it all in one piece. But just looking at the size of the lesion after the injection, I did not think I could get it in one piece. That was my thought. And it ended up being a piecemeal resection, unfortunately. So let me play, again, this is just a portion of the parts that I thought were at least demonstrated some of the hot snare technique is what I've included in the video. So I started at one end. This is the 25mm snare, and I'm trying to get it so that I could at least, get one edge of it completely. And as we're doing, I did divide it into piecemeal resection and then hemostasis, but you'll see that during, of course, it's not quite that clean cut in real world EMR. As you're doing the resection, you're going to get some hemostasis. And so we kind of, both of those will be included, I think, in this section of the video. So we're grasping the tissue. It was Raju settings, EndoCut 313, EndoCut Q 313 was what the settings were. And I checked it before we started with the resection. I checked the Irby machine or the electrosurgery unit.
So one of the things that people need to keep in mind is when you have a polyp like this one, that is draping on both sides of a fold. And that is a polyp, you have to be very careful to keep your snare parallel to the wall when you resect. When I say be careful to keep the snare parallel to the wall, the reason I say that is important is if you cut it at an angle, especially a polyp that is draping on either side of the fold, and you cut it at an angle, you may actually entrap the muscle and put yourself at risk or put the patient at risk for perforation. So something to keep in mind when you're cutting these polyps. If you are starting in your career with EMR, and when you see a big lesion like this, it will be safer for you to start with a smaller snare. It will take a lot more cuts, but with a smaller snare, you are not going to grab a lot of tissue or deeper tissue. So the risk of complications is going to be much less. So something to keep in mind. So
thanks for making that point, Raju. Yeah, sorry, go ahead.
Yeah, typically I use for a polyp like this, I try to use like a 15mm snare. And sometimes you may have to use two different snares, one bigger and one smaller. But as you can see here, Selvi is working hard because the lesion is on the right side. It is probably one of the most technically challenging polyp to resect. First of all, it is a flat lesion. It is a non-granular lesion. Non-granular lesions tend to have a lot more fibrosis, but fortunately it lifted well. But it is on the right side of the field. And what we are not seeing is how much of struggle she is having managing the scope outside, So
Thanks,
you want to
Raju.
comment on that, as you're doing.
Yeah, so that's exactly right. So I started with the 25mm snare, and then when I was seeing, you saw when I first made a cut, I didn't feel like I had good control of that snare. So I think I did one, maybe two cuts with the 25 snare, and then I switched back to my workhorse, which is the 10 millimeter snare. I just felt like I had a lot more control with that. So yes, I did use two different types of snares. Yeah, so we did, and there was also an area here where I used the snare tip for coagulation. There was a little bit of oozing that comes up a little later in the video here that we saw earlier. And I just used the tip of the snare to just do a little bit of coagulation there. I have another video after this that shows hemostasis and the tool and technique that I used for that in the next segment. But basically I tried to, go ahead.
No, go ahead, you finish.
No, I was just I started at one end of the lesion and then I kind of worked my way around to the other end. So from one end of the kind of dog bone shaped lesion to the other end is what I did. And I didn't include all of, it was piecemeal. I didn't include all of the segments because I just felt like these were at least clean and short and kind of showed the snare from start to finish. This I included because it shows where I'm kind of struggling a little bit to get the edge of the snare on the edge of the lesion. And then I also included a segment where, we closed the snare and then we didn't really grasp the tissue. The tissue kind of moved away from us. And so we aborted that maneuver and then kind of reopened and started again. So again, this is real world EMR. I'm not, this is what people who are, not necessarily experts or who don't do this every day are going to see in the course of, tackling these lesions if that's what they choose to do. Or so anyway.
You've done a good job. I think the most important thing is to keep in mind, when you're cutting these polyps, you need to have a lot of patience.
Mhm.
And you need to have a team that can anticipate what is needed. And there is a lot of work that happens on the backstage
Right.
that people may not appreciate, whether it's the assistant that is helping, the nurse in the room helping to get the equipment ready and not waste any time waiting for the equipment,
Right.
If you think about a resection, there'll be multiple attempts to inject, multiple attempts to resect, and different things to do. And then there is a time that takes for the instrument to go down the scope channel and come out. And those instrument exchanges take time.
Right.
And you could have a very efficient operation if your technician and nurse knows what to do next, and then anticipate and get ready with that instrument rather than searching for those instruments. And the
Right.
worst thing could be they're basically running out of the room to find that
Right.
instrument,
Right.
and that is a disaster, I'll tell you that. So fortunately, our group, they do a good job in making sure that they have all the equipment ready, and
Right.
it makes a big difference. And you can see here, the polyp is slipping out. But fortunately, she didn't take that cut, and she went back and grasped that remaining portion, and that's nicely done.
Okay. Shall we move on to the next segment, Raju?
Yeah.
Okay.
So let me ask Roy to comment. What does he think, and how? What can we do better whenever we see a patient like this? So far.
I'm open. Yeah, I'm open to any critique at all, please.
Selvi did a good job in getting rid of 98% of the polyp. There is still some residual area. Sometimes the residual area is hard to cut, in which case you may end up using a hot biopsy forceps to clean it up. And this is especially true in non-granular type of tumors where they can have some fibrosis underneath and they do not lift well and they tend to slip down. And it's much worse when somebody has already taken a bunch of biopsies and then send the patient to you, then you are really struggling. So I see that the Selvi is doing a hot biopsy or a cold biopsy. It looks like
Cold
a
biopsy, yeah, cold jumbo biopsy, forceps. And when I grasped the tissue, I just kind of held it a little bit longer than I normally would, just to try to kind of compress the blood vessels, which didn't work because it bled anyway.
So when I try to remove a polyp that is small like this, I try to use a hot biopsy. And the settings here we use is endocut I. I try to use minimal, I try to avoid coagulation. So the effect is 1. Effect 1 has no coagulation. And then I try to increase the duration of the cut. So I put it to duration of 3. And then the interval, if I don't increase the interval, I just put it to 1. So once I grasp, I tap on the yellow pedal. That will create a nice clean cut. So something to keep in mind.
Just a short comment, if possible.
Mm-hmm.
Congratulations, Selvi. I think that's
I didn't think anyone was going to congratulate me on this, but Sylvia, you're too kind. Too kind. Thank you.
A practical thought. What I'm doing sometimes when I capture the tissue and the assistant would close the snare just to make sure before cutting that I did not entrap the muscularis mucosa. I just ask the assistant to release a little bit, very little bit, and I move the snare back and forth times to make sure it is mobile. And then after I cut, that's a double check what we tell to our trainees to make sure that they didn't entrap the submucosa.
I think that's an excellent point. Yeah.
That's actually very important when you see a polyp on a fold. It's important for every polyp, but when you have a polyp on a fold and where the risk of perforation is very high among all the EMR cuts, good idea to check whether you release the muscle if in case you entrap it during your closure. So to loosen up the snare, like Sylvia commented, probably not a bad idea to distend the colon so that it will, if there's a muscle that is in the snare, that will fall back and then tighten it again. And the other thing is
just inject a little bit more saline and make sure that it lifts nicely for doing a new cut when necessary.
What was nice about, thank you, Sylvia, for your comments. What was nice about the injectate that we used, whether it was the injectate characteristics itself or the volume, the lesion stayed lifted while I did all of this kind of multiple piecemeal resection, including biopsy. I don't know if you can see my mouse, but what I showed you before, and then this part up here, I also, this little nub here at the top of the screen, I also removed by biopsy.
all right.
I just didn't include that. Okay, Raju, shall we move on to the next segment? Okay. So, before, during the first piecemeal resection video, I showed that I used the snare tip for a little bit of coagulation. But here is some more. This was early on in the case. And I decided, for whatever reason, because you can still see there's not much polyp still left at the top of the screen. This was one of the first snare segments that I removed. So I used a little bit of APC because we had it out. We knew we were going to be using it later on. And so I achieved hemostasis of this little bit of oozing with APC. And probably the probe should probably be a little bit further out from the scope. So one of the things, Raju, if I can just make a comment, I would encourage, if people have the capability to video record any procedure that you do and watch it. I think it just during doing this kind of project, it really gave me a lot of time for introspection and just to kind of evaluate my own technique. I think, you know, going through this process actually makes us better endoscopists. Just being able to see what you do, because when you're in it, whether it's a big EMR or just a routine colonoscopy, it's good to kind of evaluate your technique and criticize your technique yourself. I think it makes us, as I said, better endoscopists. But anyway.
It's a very important point, Selvi, you make. Every endoscopist, I strongly believe, to get into the habit of recording their video and then going back and breaking down the game. You know, that's how you can actually improve your performance. And just for the sake of some information, you know, we didn't have formal training in EMR during our fellowship. At least I didn't have formal training in EMR. And most of the people that trained in the same period did not have EMR as part of their training. And basically, I've learned, you know, talking to Roy, watching his videos, and then I recorded all my videos and then going back and watching, you know, what is it that I didn't do right, so that I could change my technique. And you know, your video could be probably the best mentor if you're honest to take the feedback that the video provides you. And if you reflect on that, your technique will get better and better.
Mm-hmm.
Oh, that's nicely done. How much of, what was your setting for your APC in this?
I think it was 0.8 liters per minute and either 25 or 30
Okay.
watts. I think it was 30 watts, 0.8 and 30.
You have a nice amount of cushion. You know, you're not going to have a deep thermal injury. So that's good. That's good.
Okay. Okay.
Yeah.
Move on. Okay, so along the APC theme, once I removed the polyp with piecemeal snare resection and trimmed it up a little bit with the parts that I still saw with cold biopsy forceps, then the next task was tissue ablation, or basically burning the perimeter of the lesion. So I included, again, these still images so you have an idea of what the end product was, because I don't know that the video necessarily shows that, but I included just some of the technique that I used just to work my way around the perimeter of the lesion. I didn't want to make it black as eschar, just a little bit of a kind of light cigarette burn, as I call it, all the way around.
Yeah. So one of the things that I want people to observe is in the center of the lesion, you could see some fat. And whenever, you know, most of us think if they see fat, we should be worried about a full thickness perforation. But in the right colon, one could have a little bit of submucosal fat. And as long as you know that your depth of resection is in the submucosa and you see a little bit of fat in between the fibers of the submucosal connective tissue, you shouldn't worry about it. So something to keep in mind here in the center, you could see a little bit of fat in the center. Actually, once Selvi finishes off right in the center, you can see some fat. So something to keep in mind. Yeah. And the other thing that I do is if I do a piecemeal resection, and especially in a laterally spreading non-granular tumor, which is likely to have a lot more percentage of high-grade dysplasia or submucosal cancer, In this case, I'm not worried about submucosal cancer because it lifted so well. The possibility of a deep submucosal invasion is out. In addition to treating the edge, like Selvi is doing here, I also treat the areas where I felt my snare resection bridged the next resection, you know, that bridging folds that you can see. So if there's connective tissue, I try to burn that connective tissue.
So Raju, I'm always afraid to kind of, especially with larger lesions, smaller ones where it looks kind of, the base of the resection looks uniform. I'm a little bit more brave. But for this lesion, I honestly, as I was doing it, was afraid to treat the base of the lesion,
Right.
just because I didn't know what I was honestly looking at. I mean, it didn't look like muscle, but I didn't know what all else was going on. Right. So would you have burned, would you have treated the base of this lesion?
Wherever you see those small islands of connective tissue, I try to do that. But I also ask myself the question before I do that, can I completely close the defect? And if the answer to that is yes, then I lightly touch on those small islands of connective tissue. You know.
You mean like here? Can you see my mouse?
Yes, yeah.
So this here?
Yeah.
Okay. Oh.
And the other thing one has to keep in mind is when you're doing such a large lesion, you have 0.8 liters per minute of organ gas going out. Organ gas doesn't get reabsorbed like the carbon dioxide. So periodically you want to get into the habit of suctioning the gas. Otherwise the patient may have pain in the recovery area, and you will be wondering, like, did I cause a perforation, or is this a gas from the organ gas? So you want to avoid all those issues by taking these small precautions of suctioning the organ gas as the procedure is going, and not wait until the end of the procedure, because this lesion is very close to the ileocecal valve, and the gas could escape into the small bowel, and you will not be able to get that gas out. So something to keep in mind.
That's right, Raju. I learned that from you. And whenever I do APC, I mean, in between, when there's no instrument in the channel, I'll definitely deeply suction to the point almost of collapse of the lumen, just to make sure that I get all the gas out. Another thing that I did and that Hazel was doing as we were doing this is like constantly palpating the patient's abdomen, making sure that it was not distended. It was still kind of soft and floppy as it was at baseline.
Right. Yeah, it's a large polyp. I'm glad that you did it, because you know the guy also has a prostate cancer that needs to be dealt with. And if he's going for radiotherapy, they would not let you go back and examine this area for at least a year.
Right. So I've told them that well, we can talk about before we finish, Raju, when the patient should come back. But I did let them know the same day once the procedure was over that I had found this lesion and that we would need to, because of course, I mean, I did the procedure on a Thursday, and on Monday he was supposed to go and get, you know, whatever set up evaluation for radiation and brachytherapy. Yeah. So I told them about that. Another thing that I did, because I told the patient and the patient's wife that the procedure was going to take, you know, 30 minutes to an hour, which is what I tell everybody. If I know it's just a routine screening exam, I had the nurse call out and talk to the charge nurse who went and talked to the patient's wife to say, hey, we found this lesion. Dr. T's working on it. It's going to take a little bit longer. We will keep you posted. So at least she wasn't out there worrying about what I was doing to her husband.
Yeah.
Okay.
That is a very important thing for all of us to keep in mind.
Yeah, I learned that from you, Raju.
Right. Yeah, it's very important, right? In a patient, you know, you expect, most people think it's a half-an-hour procedure, and then if their loved one doesn't come out in half an hour, they'll start worrying. And it's a good way, it's a good communication practice to let the nurse go. And actually, sometimes in the past, before COVID, I used to go take off my PPE, go out, talk to the family in person, tell them that, okay, we have a large and we want to take care of it today so that he doesn't need to come back. It will take time. And one should be prepared for some bleeding. So you want to prepare the patient well as you do take care of these patients. And so get into the habit of periodically updating the progress of your procedure. And nowadays it's very easy, right? You know, the nurse could call the patient on their phone and say, we completed the procedure, you know, we're just cleaning out a little bit of stuff. You know, you don't have to give a lot of details. They know what's happening. And that way, at least you can take good care of these patients.
So I see we're, in the interest of time, we'll move on to the next. So once the APC was done, I wanted to very closely kind of inspect the perimeter and the base of the lesion to make sure that everything had been ablated on the edge and all residual polyp had been removed. So that's what I'm actually doing here. Okay.
Yeah.
And then I honestly didn't think I was going to be able to close this just because it was kind of so wide. But I wanted to at least try. So this is the video of this, and this is just a couple minutes. So I just want to, so we got the, this was the MicroTech 16 millimeter endo clip. And Luis, the tech, is the one who kind of suggested, why don't we try this, Dr. T? And I said, I'll try anything at this point, because I have Hazel in the back, you know, praying while we're doing this whole thing. So and I think her prayers were all answered, because I think this went about as well as can be expected in my hands. So I wanted to show, I included this, even though it was not a perfect clip placement. I think it actually helped in retrospect. I'm not on the right edge of the lesion. I'm actually inside the lesion itself. But I included this because this is, again, real world EMR. This is what I did. But I think by doing that, what it actually did was it tented the lesion and made it taller than it was wider at that point. And so if that makes sense. So
Yep.
The first clip actually kind of pulled the lesion and made it a little bit taller. And then that made the base of it a little bit more narrow. And then I was able to put all the clips that I wanted to put. So I ended up putting 6 16 millimeter MicroTech clips on, and then I did 4 360 resolution clips on. And you'll see I kind of tried to go around from one end of the lesion to the other, as Raju has taught us. And then for the areas in between, I used the smaller 360 resolution clip.
Yeah. So when I think I'm glad that you showed this first clip. When you have a large lesion and you think you cannot close, you could actually do what Selvi did. You know, go into the submucosa and put the clip. The wound becomes smaller. So when you have a large defect like this, what I do is I take a 16 millimeter clip, a large gap clip, and apply that clip, you know, top, middle, lower third. So the wound becomes smaller. And in between those, you can put those additional clips to close it nicely. So that's something to keep in mind, you know. And I'm glad that MicroTech makes this large clip, and I believe Boston Scientific also makes this large wide gap clip as well. So it helps us to have those additional clips with a big wingspan, and especially for large defect closures.
Also for closing a large defect, sometimes I start at one side of the defect and close progressively, zip the whole defect.
Right. Yeah, it's nicely done, actually. I think one of the things that I was just thinking through this case, I never thought about it, but it's good to talk about it. I don't think I would have done anything different from what Selvi did. What happens is when you cut a polyp like this, there are multiple pieces, unless you suction as you're cutting. But if you have large piece that doesn't come through, you may end up using a net. And when you put a net in and try to take the polyp out, then you may not be able to examine the rest of the colon. So something to keep in mind, right? You have a limited view with the polyp stuck in front of you inside the Roth net. You may not be able to see any other flat lesions if there were any. So if I see this case again, I think one thing that I may do different is I look at this lesion and I know that we need to prepare, and anticipating my limitation and examining the rest of the colon, I would have, in the future, if I see a case like this, I would examine the colon all the way down and go back and try to resect. Something to keep in mind, because this is a guy who's going to have a prostate cancer therapy and he's going to have brachytherapy. And once they have brachytherapy, at least in our institution, we don't go back until a year to avoid damage to the rectum. So, yeah, nicely done.
Great, Roger. Thanks, Roger. I don't know about that, but anyway. This, as I said, I just wanted this is for educational purposes, and I welcome any feedback. I think because we're all learning, as Raju says. So that's it. There was a question in the chat. I think Joseph, thank you for your compliments. I appreciate it very much. He was asking about retrieval of the lesion. I just didn't make a video for that, just because I felt like this was all already long segments of video. I used a Roth net, and you could see in some parts of the video where all of the pieces of the polyp are actually hanging out on the screen left. I used a Roth net, and I was able to capture basically all of the pieces. And I came out with the scope all the way, and then I went back in again. There were smaller pieces that I removed through the suction channel, the polyp trap. So it was kind of a combined effort. I, again, was not able to really do a dedicated view for small polyps in the rest of his colon. I did find one small hyperplastic polyp in the rectum that I removed. Just to wrap things up, the pathology on this was tubulovillous adenoma. No high-grade dysplasia was present. And they obviously weren't able to make any comments about, margin status, of course, because, the polyp is right there on the left of the screen, as you can see all of this. This here is the polyp. Anyway, that's all I have, Raju.
Nicely
Thank
done.
you very much. I appreciate everybody's comments so much.
Yeah, I think you're going to bring him back in a year or 6 months.
Yeah, I was going to say actually, I was going to say 6 months, but I thought maybe what do you guys think about 3 months so we don't delay his prostate treatment too much? I was actually thinking about doing it in 3 months and then making sure I can clear the rest of his colon. And then that way we're not delaying his cancer therapy. What do you think? What does everybody think?
So if you are the repeat exam is to just examine the rest of the colon, right?
Well, and to examine the scar and do biopsies of the scar and that type of thing. I didn't, yeah.
So when it comes to examining the rest of the colon, you could bring it in, given the cancer diagnosis, and if the prostate guys say we cannot wait, I would bring them back whenever the next available in about a few weeks, maybe 3-4 weeks, so that, but at that time, I would let the patient know that I cannot really examine the recent resection. Even when you bring it back at 3 months, what I've seen is the granulation tissue that actually repairs this defect. It is very hard to really figure out whether there is tumor recurrence or granulation tissue. And that's what a few cases that I've done, I was stuck. I couldn't say, okay, is this granulation tissue or is this tumor recurrence? And the fact that you cut it nicely, the chances of recurrence are extremely small. And the fact that it is no high-grade dysplasia, no submucosal invasion, even if you have to bring him back in a year, I won't lose sleep on that.
Okay.
Typically we bring them in 6 months, but given the fact that he's going to have some brachytherapy, a year is not a bad idea. Only thing is you don't want him to go to 2 years.
Okay. Okay. And then, sorry, Joseph also wanted to ask about orienting the specimen. We just dumped it all in there. We just dumped all of it into the formalin container. If I'd gotten it in 1 piece or 2 pieces, I think I would have pinned it on cardboard or corkboard. But since this was just, a mess of a handful of, polyp, we just put it all into the formalin container. I also didn't tattoo the lesion. I felt like it was, you can actually see that it's basically 1 or 2 folds away from the ileocecal valve. And so I didn't, but when I go back to examine it at, 6 months or a year, I'll probably put just some tattoo, just to make sure that we can identify it, in the future.
All right. It's nicely done.
Thanks, Raja.
Just,
Thank you, everybody, for your comments.
we'll have a break next Sunday. We're not meeting next Sunday because of Thanksgiving, and we'll meet first week of December. I want to thank you all and hope you all have a great Thanksgiving.
Enjoy the Thanksgiving.
Make sure you be safe. All right. Take care. Bye-bye. Thank you, Sylvia.
Thanks a lot. Enjoy the Thanksgiving. Bye-bye.
Thank you.